Aspartylglucosaminuria is an inherited lysosomal storage disorder due to defective degradation of aspargine-linked glycoproteins with multisystemic involvement. It's an autosomal recessive condition, a disorder of glycoprotein degradation. Deficiency of the enzyme glycosyl asparginase, which cleaves the link between the protein and carbohydrate moieties of glycoproteins, causes accumulation of aspartylglucosamine, which is subsequently excreted in the urine. AGU is caused by biallelic pathogenic variants of the AGA gene on chromosome 4, which encodes for this enzyme, responsible for the catabolism of the N-linked oligosaccharides of glycoproteins. At least 40 different pathogenic variants have been described so far, and the majority being missense variants, while the remaining pathogenic variants include microdeletions, insertions, spliced site variants, gross deletions, and complex rearrangements. The vast majority of identified individuals are of Finnish descent with a prevalence rate of 1.5 to 5 per 100,000 live births in Finland. AGA enzyme cleaves the N-glycosidic bond of arginine-linked glycoproteins, removing L-arginine-linked moiety from the glycoprotein, generating L-aspartic acid, ammonia, and free N-acetylglucosamine carbohydrate chain. The defective AGA activity leads to the accumulation of undegraded aspargine-linked glycoproteins in tissue lysosomes and body fluids. Hypertrophied lysosomes with glycoprotein accumulation can be observed in all tissues in patients with AGU. Defective degradation of aspargine-linked glycoproteins is associated with multisystemic involvement. Clinically, the disorder is characterized by a period of normal growth until the age of 2, followed by a plateau phase of slowed development throughout childhood and a rapid deterioration in early adulthood. Despite this, median life expectancy is around 45 years of age, suggesting a prolonged period of poor neurocognitive function and very limited quality of life. Primary manifestations of AGU include progressive deterioration of psychomotor function with skeletal and connective tissue abnormalities leading to premature death. Largely non-specific clinical symptoms and overlapping with other well-established clinical syndromes such as autism spectrum disorder further contribute to delays in the AGU diagnosis. Cause faces macrocephaly, inguinal and abdominal hernias, recurrent upper respiratory and ear infections, clumsiness, hyperactivity, and sleep abnormalities are commonly observed in children with this condition. And deteriorating cognitive abilities, loss of independence and socialization, but sleep abnormalities, with increasing behavioral problems, agitation, aggressiveness, cause a large burden on AGU patients and their caregivers, adversely affecting their quality of life. AGU clinical manifestations and long-term outcomes in adults. Hematopoietic stem cell transplantation has demonstrated efficacy in several lysosomal storage diseases, as we've heard today, by providing enzyme replacement therapy in somatic viscera and decreasing substrate accumulation. Moreover, donor-derived monocytes cross the blood-brain barrier and differentiate into microglia and secrete enzyme in the central nervous system. And this has been shown to improve patients' neurocognitive outcomes. Therefore, I would like to present a family of 4 siblings with AGU, one of whom has been transplanted in infancy, and their long-term follow-up. These cases demonstrate a neurodevelopmental heterogeneity based on the formal neurodevelopmental assessments. So the patient number 4, female patient who is currently 18 years of age, she was diagnosed at 5 days of age by family screening. She had 3 older siblings already affected with AGU. At diagnosis, aspartylglucosaminidase activity was significantly low in leukocytes. At birth, her weight was at 9th centile, height at 25th centile, and head circumference at the 2nd centile. Her MRI head was normal at that stage, and she underwent hematopoietic stem cell transplantation at 7 months of age. She received 6 out of 6 HLA-matched unrelated donor cord blood transplant at 7 months. She also received intravenous busulfan and cyclophosphamide conditioning and ATG post-serotherapy as part of the local regimen. Shortly after the transplant, she had evidence of veno-occlusive disease despite low busulfan levels, and this was managed only supportively, and she recovered without any further intervention. At 10 years of age, she had a neurocognitive assessment which confirmed that her skills remain behind the majority of peers in all areas assessed. At that point, her full-scale IQ was very low. On a positive note, there was a significant improvement in her biochemistry. Aspartylglucosaminidase activity was within normal ranges in her leukocytes and plasma. Her height was at 25th centile, and her weight was very high, above 99th centile. The MRI scan was age-appropriate with no abnormalities. She required support during her education as well as everyday activities. She had documented obesity at that point. She was also diagnosed with psoriasis in her childhood and required treatment with immunosuppression. At the last follow-up in the adult metabolic clinic, she was very communicative, very engaged in the conversation. She was able to answer all questions, and she was very keen to ask questions about her long-term follow-up. She had moderate intellectual disability, but despite that, she was able to communicate well. She had bilateral hearing impairment and required hearing aids. She attends college 5 days a week and enjoys peer-to-peer interaction. The physiotherapy assessment confirmed that she had broad-based gait, but she was able to walk independently. And she still requires support with activities of daily living, and she has her personal PA. Her BMI was 44.5 kilogram per square meter and was very high, probably resulting from very limited physical activity. She is also known to have refractory iron deficiency anemia requiring hematology input. This table summarizes outcomes in all 4 siblings with AGU. The patient who was transplanted is in the last column on the right. However, her older 3 siblings had very severe neurocognitive disability. In particular, two older brothers required an input from neuropsychiatry due to their severe agitation, self-harm, insomnia, and required treatment with antipsychotics. The eldest brother remains institutionalized. They are not able to communicate verbally. The sister, 33 years of age, is able to communicate using single words, and she may answer simple questions. The MRI scan in two eldest brothers showed they had very severe brain atrophy. They also had coexisting Fabry disease, and it was the main reason for their follow-up in the metabolic clinic and for the MRI scans. They are not treated for Fabry disease. They have significant balance problems with mild ataxia documented on SARA score in one of the brothers. And abnormalities in this condition, abnormalities in endochondral ossification in the vertebra lead to scoliosis and short stature in adults. And the long bones have thin cortices and poor trabeculation. However, this family, despite having ataxia and balance problems and slightly abnormal gait, they did not have significant joint problems as such. And what was striking was hematological abnormalities. All three siblings who were not transplanted have marked neutropenia and thrombocytopenia as compared to the eldest sibling who has neutrophil count and platelet count within normal ranges. So in summary, the patient post bone marrow transplantation showed biochemical stability. Her urine chromatography was still able to detect a band corresponding to aspartylglucosamine compared to pre-transplant, but it was significantly reduced. And in leukocytes and plasma, glycosyl asparginase activity was comparable to healthy controls. She remained substantially behind her peers and continues in the special education. She requires support during education. However, her family report improvement in language, and there's no evidence of regression. Her function is also much better compared to her brothers who were not transplanted, with much less challenging behavior. And given her clinical trajectory, it may be that other factors such as genotype and intensity of allied health therapies also play a role in modulating the outcome. Neutropenia and thrombocytopenia are common features in untreated patients with AGU.
I'd like to thank Dr. Stepien for her remote, beautiful presentation showing some of the challenges of AGU. And I think now it's opportune for us to invite Dr. Lund to speak about current approaches to treatment and outcomes. Dr. Lund, as you already know, is a transplanter from the University of Minnesota, very experienced in a whole range of inherited metabolic diseases. So, Troy, thank you for being here, and over to you.
Sure. Thank you. As I've said to a few people, this is one of my favorite meetings when it happens every few years due to its small size, ultra-rare diseases, and I always enjoy attending it. Generally, I can cover all the diseases in 20 minutes because there aren't that many transplants, and for some, there's zero. So I tried to break it up, but it's not going to be super long just due to the lack of experience that we have globally. So I don't need to necessarily go through all the definitions. Whoops, I went backwards. Okay, that was you. It works. So glycoproteinosis, we have defects in processing sugar-coated proteins. We have a buildup of the unprocessed precursors. You end up with skeletal disease, inflammation, neurodegeneration. There are very few pharmacological treatments, and bone marrow transplants attempted in the hopes of providing the missing enzyme and attenuating disease progression. So that's generally the goal for all of these. So bone marrow transplant was pioneered here at the University of Minnesota in 1968 by Robert Good, who did the first successful transplant in the world. It was for a child with an immune deficiency, and that child is now a man who's approximately 55, 56 years old and alive and well. There are alternatives to BMT. There's cord blood, there's peripheral blood. We call these things, all these go by stem cell therapy, and there's all sorts of nomenclature. I call it stem cell therapy, but the different terms get thrown around. Sometimes people just call everything BMT, even though it's not. And then we learned about providing the missing enzyme through pioneering works from Dr. Bill Crivet and Dr. Chet Whitley, who performed the earliest transplants here in the MPSs. And so really laid the groundwork to suggest that there are cells in the marrow that end up going to the various organ systems and providing the enzyme you are missing. The liver, heart, spleen, lung, very easy to reach, moderately easy to correct, brain, not so much. And so when we talk about the brain, it's this bone marrow microglia connection. So the microglia cells are kind of a hematopoietic cell derived or hematopoietic cell that's in the brain. It's the cell after transplant that gets up there. It doesn't get up there very much, though. And we talk about engrafting the brain, which is what my lab studies. It is a maximum of 6%. So it doesn't engraft super well. And it's that 6% we're relying on for disease correction. We know it occurs at about 3 months after transplant and probably keeps going for the next year. So what do we know about transplants for AGU? Well, we can summarize it in just 4 slides, basically. It has been performed in mice early on. You do get correction of lysosomal accumulation in mice. I'm just showing the title of the paper where this was initially published. You can see that wild-type brains are in the top slide. Middle slide is affected AGU brains. It was an AGU bone marrow transplant to an AGU mouse, so it wouldn't have any effect. You'd see disease pathology, and you could see all the massive accumulated lysosomes there in the white. And then when you do a bone marrow transplant with healthy marrow or unaffected marrow into AGU mice, what you see is that you get some correction of the sick lysosomes. So what about people? So I've gone back and forth on this over the years. Every time I give this talk, I have to kind of look at the literature and see if there are any updates. Generally, there aren't. This is one of the original studies looking at several AGU patients, male and female. This looks at their developmental age versus their age. The triangles are boys. The open triangles are untransplanted. The closed triangles are boys that got transplants. And this isn't a pointer, is it? So here it is. So you can see there's 3 boys down here underneath the other ones. That doesn't look great. Girls are in circles. The untransplanted girls are scattered around here. A couple of transplanted girls may or may not be higher or lower. It's really hard to say, and I understand that. So and overall, the theme is, well, we weren't really encouraged by this data. So then we kind of revisit this. And we find another manuscript, an experience from 2006, a couple of kids transplanted 10.5 and 5.7. They did 5-year follow-up, no neuropsych or clinical deterioration was noted, stable expression of AGU. They looked at some markers of neuronal and axonal degeneration, which were improved. They looked at MRIs, which were better in these two kiddos. And they report that none of the children lost capabilities and since transplant. Moreover, improvement was shown in biochemical markers and MRI, suggesting a benefit. So now we're going back the other way. It's like, well, maybe transplant does have some benefit. I just included some of the biomarker data so you could see firsthand that, yeah, some of the biomarkers are very high. And then after transplant, they seem to go up and then come down. I mean, it's a little bit shaky. I'm not sure I entirely believe the story here, or even that is meaningful because it's so variable. But you can look at some of the neuropsychologic data, pre-transplant and post-transplant of where the children are living, and they seem to be doing okay, or at least holding their ground. At least, you know, that's the interpretation that the authors have of what they've assessed. So that's great. So it looks like, again, a mixed picture, but a bit more positive. And then there's another case. So this is much more recent case series. So this wasn't out last time I gave this talk. It's 4 kiddos, ages 9 years, 5 years, 5 months, and 7 months that went through transplant. And the authors claim, yeah, there's varying outcomes. They looked at these kiddos with follow-up over 10 years. And they suggest that there's heterogeneity, which is absolutely true. And let's see what they looked at in terms of some of the corrections. So they looked at Enzyme, they looked at urinary aspartylglucosamine, and of course the excretion is very high pre-transplant. After transplant, it's usually reduced by 90%. Seemingly true for many of the storage disorders, so that's not surprising. And then the neurocognitive stuff, which you really can't see, it's pretty small in type, but it's the 4 patients across the top and kind of the tests that were done and where they live in terms of their percentile. And I think you can see that, you know, patient number 1 here is still functioning at less than 0.1 or less than 1 or 0.1 percentile in many of the tests, but that was the older patient. And the patient that's really doing the best is the 5-month-old who is functioning at a much higher level than any of the other patients. And so again, that take-home message becomes earlier transplant is beneficial. Even though I state there's no age cutoff, we will always argue for earlier transplant as early as 5 months, as was in this case. So the abstract conclusion then, and this is text taken from the abstract, is that the third case, transplanted prior to the onset of neurocognitive involvement, is developing normally despite severe phenotype in other family members, which I didn't get into, and suggests further research should be done to examine the role of early transplant AGU. So now we're much more positive than where I started with many years ago. But again, we've only covered 6 more cases. So then my own summary is like, well, when you look at it all together, the data is still mixed. You saw us go through an error there of transplant for AGU. In my opinion, the greatest transplant benefit exists for the youngest age at transplant, and we should somehow continue to accumulate this data to the best of our ability through registries or whatever mechanism you'd like. Thanks.
Very much, Dr. Lund, for that comprehensive overview, what we know about this. And I think what you've said really reinforced earlier comments, and that is it seems that the younger, which usually means the earlier in the course of disease progression you can intervene, the greater the likelihood of effectiveness. And speaking as a neurologist, it seems to me the point is that the longer the disease progresses, the more neuronal fallout you have. And even the most successful stem cell transplantation is not going to replace lost neurons. And I think that's the message we think of as neurologists. And I think it's borne out by the data we have, recognizing its limitations. Do we have any other questions from our online audience, or maybe Dr. Whitley has a comment?
Yeah, no questions from the online audience.
Dr. Lund, you made the key point is age makes all the difference, right? So when we first started doing transplants for Hurler syndrome, we transplanted kids who were 2 or 3 years of age. And, the kids survived. It was much better survival, but the neurologic outcome was marginal. However, once we could get that age younger, we saved that 20 IQ point loss for the period of under treatment. So now we're doing newborn screening. We're coming out with kids which have normal IQ. The same was with Sanfilippo syndrome. The handful of kids with Sanfilippo syndrome who got transplanted, well, they're not diagnosed until they're 5 or 6 years of age. The game is lost neurologically by that point. So why would this be any different? You've got to transplant kids who are very, very young to really get a good signal. If you get anything like a biomarker that goes down, or any stabilization at all, that is a strong enough signal to say, go right ahead and transplant. Why so late? Why 5 months? It's pretty fast to use slow bone marrow transplanters. Us geneticists really jump on it right away. We do newborn screening and we get right on it.
We appreciate that chin up for geneticists. Maybe Dr. Wolf has some further comments.
Quick question. Have you done any lentivirus transductions of HSCTs to boost the enzymatic activity, which has worked in some animal models?
Lentiviruses? Oh, yeah.
For stem cell transduction.
Yeah, I think it's a great idea. I don't know that there's a lot of research going on in the murine model field for AGU. I showed a couple of papers, but I don't know where that's happening anymore, if it's happening at all. I would imagine that approach would probably work because it does work pretty well in the other animal models, but I don't know that it's been tested. I actually should search for it, but I don't think it has been. It's a great idea, though.
Thank you, Troy. For those of you who don't know Dr. Janis, she is a very distinguished researcher at the University of Minnesota who has worked on many of these rare diseases and made many contributions over the years, and is expert in measuring outcomes, amongst other things.
So I do have some slides that maybe could be pulled up, but I was wondering, Troy, Dr. Lund, I had been reviewing the closest thing to some natural history studies. And when I was looking at AGU, there was one study in 8 patients that showed MRS, showed elevated aspartylglucosamine. Do you think that might be an outcome measure for this disease, or?
It's not routine for us to do MRIs after transplant, though we certainly could. When I think about this disease, it's so rare.
Yeah.
The patients I've seen have been at conferences, and I rarely get any referrals for them. So it's been pretty tough, but we could look at it post-transplant, or the centers that are doing this. I would say, the Finnish population is where I would suggest we focus because it's much more common.
Yes. Yeah, the study was in 8 patients, 5 non-Finnish, and they had a decline in nonverbal IQ. I'm trying to see their age ranges here. I don't see that. Deficits in gross and fine motor skills. And I was just curious on that brain MRS, because we're always looking for some kind of great, easy to measure biomarker. So I will just talk a little bit on outcomes here in general. And let me see if I can make this thing work. Do I hit the green? So here's diseases that we're discussing at this meeting. And just in general thoughts for the patients listening in, and maybe the patient advocacy groups. One of our, if we want to get a treatment to market, we first of all have to identify meaningful outcome measures. And that's one of the major goals of this meeting, is to start thinking about those things. And as we've already discussed, that this information largely comes from our analysis of natural history studies, but the natural history studies need to be linked with peer-reviewed publications of those studies. And we need to define from that then what is meaningful. It's very important to have good tools that are validated for measuring the things we want to measure. So this is all information that you're all aware of, but I'm just sort of reviewing it here. One of the things, I was given the challenge like 15 years ago to work on a group of rare diseases, the gangliosidosis. And most of the literature at that time that I looked at was talking about what happens. And as we started seeing all these children with the different phenotypes and adults, another question became important, not just what happens, but when it happens, and is there a predictable sequence of events? And if we can see any predictable pattern, that creates something that a pharma company could use as a measurement of disease progression. Some of that data we can actually collect from real world data. And I just threw that in there because we all know the challenges of having patients travel to centers of excellence and the enormous amount of funds it takes to fund a natural history study. Can we be creative in getting at least some of the early information through real world data? And I think we're seeing a lot of that here today in these presentations. And can some of this be done remotely? Dr. Isengart was talking about doing neurocognitive assessments remotely, right, earlier today. So that's fantastic. If we can start doing more of that, even though we all love the benefits of seeing people face to face in person like we are here today in this room, being able to have use our current tools to connect remotely might really help advance our progress for these natural history studies, especially with these ultra rare diseases. And I was looking for on clinicaltrials.gov just what is going on with natural history studies for the glycoproteinoses. These 3 studies come up when you search for each disease. The top 2 are recruiting, the bottom one is completed. And they basically cover all the glycoproteinoses. So there's great benefits in this, but they could be watered down a little bit. The last study that is completed never had any publications. So even though there might be a lot of data there, it's not useful to us because nothing was published on it. Specifically, if we look at disease specifics, there's 2 natural history studies that have been completed for the alpha mannosidosis, at least on clinicaltrials.gov. Now, of course, there may be other ones elsewhere, but this is important. There's only 2 studies. They were quite recent, and there's a number of nice publications, mostly probably based on those 2 studies, but we now have a enzyme replacement therapy for alpha mannosidosis, and that is directly correlated with these studies. I looked for the AGU natural history studies that Dr. Lund just talked about. There was 1 study that was terminated, so that's it. So there's no studies on clinicaltrials.gov for natural history. There are some peer-reviewed publications between 2015 and more recently. With the first one had 25 patients, the other is this 8-patient study I was talking about. And there's a review article. For beta mannosidosis, I could not find any specific natural history studies that are ongoing for that right now or that have been done. And likewise, no natural history publications. Now, I might have missed something. I did find 4 or 5 case reports dating from 1997 to 2023 and some review articles. So just kind of giving us a feel of this landscape we're working with these ultra rare diseases. Fucosidosis, no specific natural history studies currently on clinicaltrials.gov or in the past that I could find. Some peer-reviewed publications on natural history. One was a retrospective review, but it had 77 patients, so this is great. It was done in 1991. And a few case reports, and that was all I could find. Schindler disease, I could not find any specific studies for it, zero results on natural history publications. However, we have Dr. Desnick will be talking on this. This first publication here was a key publication to identifying neurological aspects of this disease in 1990. And there's been a number of other case reports on this. Interestingly, in the bottom, I highlighted that basically in the last, I don't know, 30 years or something, there's been 20 cases published. So as you can see, there's a shortage of information here on these. Sialidosis, one natural history study that incorporated mucolipidosis in general, and that study was withdrawn. No peer-reviewed publications, some case reports, and mucolipidosis type 2 and 3. This is the general study that covers all the mucolipidoses, but it was withdrawn. And I could not find any natural history studies or peer-reviewed publications. I'm sure there's some out there, but it just shows when you go through the National Library of Medicine, they're not popping up right away. So I just wanted to kind of present that overview because it gives us, it kind of, for me, it says this group here today, one of the reasons we're here is to, so in a few years, if we did this same slide set, we'd be showing a lot of publications. We'd be showing natural history studies that are collecting data and getting publications out there. And that will lead to treatments. I know Dr. Stepien mentioned a number of times, she and I had some email correspondence, but she likes the SARA. This is as an outcome measure. Now, this might be applicable to many of the diseases we're discussing at this meeting, the scale for assessment and rating of ataxia. Like any test, it has its pros and cons, and there might be a lot of critics for this test. There are a few advantages I just wanted to discuss with you all as we're thinking about outcome measures. It does measure ambulation and balance. It also helps to measure speech disturbances and put a number on that. And these are important aspects of the diseases we're discussing. And it is quite easily scored. And this is just a summary of how it's scored from 0 to 40. With the training for it is, now Dr. Patterson might weigh in on this too, because he's had some experience with it, but kind of anybody can do a SARA, and you can do it at your center. Now there might be inter-rater variability unless it's sort of monitored and you're trained on it. But we have even used this in our clinic for patients who are in New York State, and we prescribed a drug and we want to see if it's helping. Can the local neurologist do a SARA? She said yes, she did it easily. She'd never done it before, but she said at least she will be doing this for the patient every 6 months. I don't think you have to get paid to do the SARA. It's not like something you have to pay for a licensure to use or to do. And the equipment required is a stopwatch, a 10-meter walkway, and an examination table. And it's estimated to take about 22 minutes to do. So it's quite easy to administer compared to some of the other tests, probably greatly less expensive. And you don't have to, it requires not a lot of training to learn how to do. And so there's certain advantages of this because it is, again, looking at ambulation, stance, balance, which affects a lot of these diseases we're talking about here, and also speech, which greatly affects the diseases we're talking about here. And then Dr. Patterson can talk to this, the functional SARA. The FDA apparently likes the SARA right now. So that's the other reason I'm bringing it up. And they like to take the total score and then take a subset of the domains, gait, stance, sitting, and speech, and do a functional SARA based on that. I don't know how long they'll like it, but right now they like that test, and it's kind of nice. It's kind of helpful to know what they are looking for as something that they would deem acceptable to them if you want to get your drug into clinical trial. And lastly, I think we talked today about, are all these outcomes that we're talking about, do they actually translate into something that's meaningful to the patients? And this is where I think we've had a great disconnect over most of our lives in research, oftentimes. Do these biomarkers, these magical biomarkers, or these indicators of, they might have a very strong correlation with certain organ health or some matter like that, something like that. But are they actually translating into a better clinical outcome for the patient, as well as a social and psychological and the emotional health and the family quality of life, etc. So I think what I heard Dr. Patterson saying, if I can kind of summarize your comments earlier, is we don't want to have just a scientific objective marker or some quality of life marker. We'd like to see the outcome measures, if possible, achieve both, right? Yeah. And that is actually kind of new in scientific research to really make a big effort in that direction. I just brought up this thing called clinical benefit response. It's kind of a interesting concept. I ran into it about 25 years ago when I worked in oncology, and a drug got approved for pancreatic cancer, FDA approved based on clinical benefit response. It actually extended the lives of the patients by 2 weeks, but it got FDA approved. And they said, well, it's also showing a clinical benefit response. It's having a positive impact on the patient's overall well-being. Granted, if you do clinical benefit response, the FDA expects you to do a follow-up study to actually confirm that it's actually doing that. So it's sort of to help accelerated approval. I'm not suggesting this for us, okay? I'm just saying conceptually, philosophically, we're thinking a little more about that. That was just my little 10-minute talk thinking about outcomes. But do we need to move on to our next speaker? So Julie Isengart might want to come up here, and we were talking about, so far we've talked about alpha manocytosis and AGU. Are those the only two diseases those are the only two so far? Okay. So I guess we're open to questions or comments from the audience on, you have a comment? For parents, patients, families, and researchers on ideas that we have at this point on what might be a candidate for meaningful clinical outcomes for these two diseases.
Yeah. Thank you. That was a really good talk. Obviously spoke a lot to my heart. One of the things I want to say is we're, remote assessment is really important. It's important for overcoming the challenges of travel, whether those are practical challenges in terms of just distance. Often the diseases are sort of time consuming enough, and it can be really hard on the affected person to travel and hard on the family to support the travel. There are only so many rare centers that are doing this kind of thing, so it can really be quite a distance. The downside is that there are some really specific behavioral skills that are needed to do direct assessment of the affected person. We have some observational options to sort of watch people through videos, but those are not really as standardized, and they can be pretty time consuming, and they require a lot of, sort of precise technology from the families too. So I do want to acknowledge that, the ability to sit at a computer for a certain length of time, even if we try to keep it brief, follow instructions, even if an individual is nonverbal, there can be still some computer assessments, but it really does, at this point in my mind, bias what we're finding toward individuals who have the skill set to participate in a remote assessment and have those regulation skills. On the converse, a benefit is to increase representation. So we can do assessments with parents whose children are no longer with us. We can do we can use a lot of the family voice, and things can still be reported, and important information can still be gathered, even if their person cannot sit at a computer. So it's just sort of, things aren't perfect, but we're trying really hard to solve some issues.
Thank you, Janine. That was a beautiful overview, and thank you for your comments as well. Julie, I just want to make a couple of comments about the SARA. This was used as the basis for approval of N-acetyl-L-leucine for Niemann-Pick disease last year. Interestingly, that is a validated scale. You don't have to have formal training, but in a clinical trial, it's required. So I did that. For those of you who are interested, you go to the German Center for Neurodegenerative Diseases. There are 173 videos to watch and rate. You have to get at least 80% on the score. It is extremely Germanic, with apologies to our German friends, and expensive to do, but it is validated. The FDA then took this valid scale and invalidated it by taking out the bits they liked and rescoring it. It didn't matter in the case of the studies that were done, because every single primary and secondary outcome measure was positive, which led to approval of the drug. But, it is a potential tool which is sensitive to change fairly rapidly. So if you have a disorder in which the burden of disease is falling on the cerebellum, which is not just movement, of course, it affects cognition and affect as well, then it's a good candidate. And in the case of most lysosomal diseases, including the glycoproteinoses, at least pathologically, we know that the cerebellum is very frequently, if not universally, involved. So it is potentially a useful outcome measure, because it does have a track record with the FDA. The other comment I wanted to make about remote monitoring is you made very important points about the difficulty. I'm sure you're very well aware of the studies that were done by colleagues at the University of Rochester in New York in neuronal ceroid lipofuscinosis, where they showed that in the NCLs, or at least NCL3, you can actually, in a reliable and reproducible fashion, do cognitive evaluations remotely. So that is important. And I think part of it, as you say, is it's difficult for families with children, particularly with neurological disabilities, to travel. Let's face it, it's hard for all of us to travel these days. It's just difficult. If your child has neurological impairment, it's even more so. And the opportunity, whilst you lack some of the controls that you might have in an office environment, on the other hand, you get to observe the child in their home environment. They're not exhausted by travel. So you may actually see them at their best in a familiar environment. So there are always trade-offs, but I think it's really a great area to explore that I think recognizes the burdens on the family, trying to minimize those and to get a better sense of what's really happening in someone's life. There are all the technical issues to do with videos and so on, but I think it's a really important area to explore.
Would it be possible with remote visits, telemedicine or evaluations? So you're missing some of the pieces that you consider very important when you're doing it in person. Could you increase your N? Could you increase your study population? And would that maybe help balance out some of the analysis or?
No, I think you're right, Janine, because it would potentially mean that patients who might not be able to participate because it's just not possible for them to travel could do so at home. And certainly in our case, for studies, one of the things we've been designing is to have very clearly laid out protocols to do videos at home, to do recordings, because of course, one of the issues that's always a concern in clinical studies is bias. If you're an investigator, you want your treatment to work, you want your patient to get better. If it's your child, you want them to get better. So one way to deal with that, for example, is to record the examination and then have a blinded evaluator rate the patient. So in the arimoclomol studies in Niemann-Pick C, I actually made videos with patients at a gathering, not unlike this, a family meeting, which were then rated to establish the reliability and reproducibility of the instrument that was being used. So I think these technological tools are really important to use, and that it means we can potentially expand studies. And that's tremendously important in ultra-rare diseases, because you have these competing demands. In clinical trials, ideally, you're going to have very well-matched subjects. Traditionally, the FDA demands that you have placebo groups. Well, for some of these patients, I think that that's a practical and ethical issue, which is why it's so important to have natural history studies. But I think that by using these sort of techniques, we can make sure that we're getting as much data as possible on as many patients as possible. So I think it's really important to pursue.
Great. Any questions coming in or no?
I was totally impressed. And if I caught this right, you also have some experience with gangliosidosis. So this is where we struggle also with endpoint tools. Do you think the SARA test would be expandable into gangliosidosis, GM1, GM2 gangliosidosis?
You know, I think, oh, I was going to say, I think it could be used definitely in the adult onset form. Go ahead.
Yep. And a phase 2B study used the SARA as the outcome measure in GM2 gangliosidosis that included children and adults. And that's published in Neurology, and I can share the data with you. So it has been used in that setting.
And the patient in New York I was talking about, we started her on an off-label drug, and she's too ill to travel to Minnesota. She's 45. So her neurologist is using the SARA to kind of help us see if it, because she has balance issues right now that are one of her biggest concerns. She's having a lot of falls. So it was at no extra cost. Apparently the physician's not billing the insurance a 20-minute SARA or half-hour SARA. It might take a little longer in someone very disabled to do it, but at least it's one way for us to say, is this helping her with some of her major concerns right now with this off-label use? And I was struck by the ease of doing it and trying to find things the FDA likes that they're less likely to put up a resistance to if you were to propose a therapy to go into clinical trial. So, and then as Dr. Patterson said, he's working with N-acetyl L-leucine that has been, we've been using the SARA, and yeah, for FDA approval. Yeah.
Hi, Chet Whitley here again. So this is wonderful. We're coming up with all these tests that can be done maybe more conveniently, but still FDA approved measurable outcomes. I think we also simultaneously should address the different genotypes and also how clinical trials are done. So when I say the latter, remember the first study is always phase 1. It's just looking at safety. So you can treat anybody you want, and you're looking at, regardless of age or a disease, but you prove that the drug is not injuring the patient, or at least defining what the adverse effects are. You like to use that phase 1 study to also acquire the efficacy data. On the other hand, phase 1 is almost always done in adults, right? People who are 18 years of age. So think about that. But related to that, but somewhat different, is that every single, quote, disease that we've delineated here probably has more than one phenotype. There's the infantile. There's the late onset. And as you broached the gangliosidosis, you found there were 3 initially in the literature, but then you subdivided it into 4. And you would probably have to have different tests, different measurable outcomes appropriate for different ages. So what I'd like to see outcome of this meeting is a grid where you say, for disease X, number 1, how many clinical phenotypes are there and how you define them? Maybe it's by mutation, maybe it's stage of onset. And then for each of those 3, or call it 4 clinical phenotypes, what are the appropriate tests for that age group, which will be different from the next age group of onset than the next phenotype, intermediate, say, or the late onset. And beyond that, because we have a psychologist, one of the world-class ones in these diseases here, we tend to focus on direct measures of cognition. And I don't know the SARA, but I want to also go back and say, are there indirect functional ways when we don't want to rely just on some measure of cognition, but function? There's, I'm not sure what it's called, I forget, an index or a combination of clinical features that add up to a score. So I think the Hunter syndrome, the drug was approved based on three different things like organ size plus reduction in GAG plus something else. So I don't have an answer to that, but this is going to be a real paper. If it's going to be a real clinical study, those all have to be considered. Gene specific, genotype specific, or clinical phenotype, and then also what you can do. And one more thing I'll just throw in there. There are some tests that could be done home by remote telemedicine, whatever. There's some you want to do ideally in a clinic, but then not all clinics are well skilled to do the sophisticated testing that maybe Dr. Isengard would do. But are there other tests that can be done in almost any clinic? Like the 6-minute walk comes to mind. Maybe the SARA can be done by a professional at almost any clinic. So there's a lot of parameters to consider. But if you're seriously going to do an effective natural history study for any of these, all those factors have to be considered. And I think that's our mission here.
And just a note, we're a little past time.
All right. Thank you, Chet. Thank you to both our speakers. Beautiful work.
Thank you.
You'll be back, Janine.